Hi, my name's Nicky Stanford and I'm currently the orthodontic senior registrar at Liverpool Dental Hospital, Countess of Chester Hospital and Alderhay Children's Hospital in Liverpool. The paper that I'm going to describe for you today involves a study undertaken during my time at Newcastle University, and it's entitled Adult Orthodontic Patients' Views Regarding Dentofacial Normality, a Qualitative Study. This will be published in the March 2014 issue of the AJODO. Traditionally, the concept of normality in orthodontics is related to measured biological variables which allow us to clinically assess our patients on a daily basis. Probably the seminal work in this area resulted in Andrew's 6 keys to normal occlusion. Unsurprisingly, there are a range of different ideas as to what constitutes a normal occlusion. Now, this is similarly the case when we assess our patients' faces. There is a multitude of hard and soft tissue measurements which allow portioning of any given feature into or out of normal limits. These measurements can range from tephlometric variables to the classic canons of ideal proportioning of the hard and soft tissues in order to achieve an acceptable facial balance. However, there is very little literature on what our actual patients view as dentofacially normal. It is uncertain whether our patients' views relate to what we actually measure. The aim of our study was to examine the concept of dentofacial normality from the orthodontic patient's perspective using qualitative methodology. We conducted semi-structured interviews with patients attending for an initial orthodontic consultation. We purposefully selected patients that we felt would have different concepts of what they would consider dentofacially normal. From the analysis of the collected data, 3 main themes emerged, each of which I will illustrate with quotations from the dataset. The first theme involved the components of dentofacial normality. What constitutes a normal dentofacial appearance was described as lacking what was considered to be an obvious, visible, or functional difference. However, there was the underlying view that normal does not necessarily equate to perfect dentofacial features. The subjects acknowledged that more subtle differences are acceptable and that it would be unrealistic for everybody to be exactly the same. The second theme involved where patients' views of dentofacial normality derive from. Dentists can play a role, both positively and negatively, in encouraging or discouraging treatment. Family and peers can play a role not only in externally influencing opinion, but also in the patient's own internal observations of what constitutes a normal dentofacial appearance. The role of the media was described as twofold. There was acknowledgement of the perfection often portrayed, and this was usually accompanied by specific examples. However, it was also described that this may not be what real-life people actually look like. The third theme concerned the impact of dentofacial abnormality at a biopsychosocial level. Understandably, difficulty masticating effectively was described as manifesting from an abnormal position of the teeth and jaws. There was also a perceived psychological impact, both in self-esteem and self-confidence, when perceived dentofacial abnormality existed. Similarly, social implications were evident. This resulted in a certain amount of anxiety when meeting new people in both a platonic and a romantic context. The data also showed evidence of the role that stigma can play. Felt stigma develops from the concern that having abnormal features may result in a person being viewed negatively. The patient may then seek to alter their behaviour in order to mask their appearance. Enacted stigma develops with negative opinions manifesting as discriminating behaviour from others. This results in the individual becoming embarrassed by their dentofacial features, as, unlike with any other medical condition, they can be difficult, if not impossible, to hide. In conclusion, this study demonstrates that our patients do not seem to describe normality as discrete variations from a given norm. They construct their views based on their own observations and those of others around them. They also describe how lacking what they see as normal features can have an impact biopsychosocially on their daily lives. What this shows us as clinicians is the potential for discord between ours and our patients' views of normality, subsequently what is deemed to require treatment. Following on from this study, I feel the concept of who does or does not need orthodontic treatment requires further explanation, alongside the potentially significant role of stigma in both the need and the desire for treatment. I'd like to close by thanking my co-authors Justin Durham and Bill Ip for all their help and guidance during this project, as well as all the staff at Newcastle Dental Hospital's orthodontic department for their support during this study. I'd also like to express my gratitude to all of the patients who agreed to share their honest thoughts and perspectives with us. Finally, I'd like to thank you for your attention during this talk, and I hope that you enjoy reading the paper in the HAODO.